we're very proud of that association with the International POSI Study Group. He has numerous awards, including 8 Best Science Paper Awards from POSNA. And as you're all aware, we had the pleasure of meeting him in 2019 at the Silver Jubilee Conference of POSI, which was held in Mumbai. Our next speaker is Dr. William Morris, who is an associate professor at the University of Texas Southwestern Dallas. He is a close associate of Professor Harry Kim, and he's a pediatric orthopedic surgeon at the Center for Excellence in Hip at the Texas Scottish Rite Hospital. So we have 2 excellent papers today, both from the same institution, and we're really proud and honored to welcome both our speakers and authors for this session. Thank you, Harry, and thank you, Will, for joining us. We have 2 moderators from POSI who will be leading the discussion, and that's Dr. Hitesh Shah, as you all know, is from KMC Manipal. He's done a lot of work in Perthes disease, taking over the mantle of his predecessor, Professor Benjamin Joseph, and he's done an amazing job in leading the work on Perthes disease from India. So he will be moderating that session on the femoral head paper, whereas Manoj Padman will be moderating the session, the paper by Will Morris. Manoj is a pediatric orthopedic surgeon and a member of POSI. He is at the Rainbow Children's Hospital in Delhi and Fortis Hospital in Gurgaon. So we'll begin by requesting Professor Harry Kim to share his presentation and to start his talk. Thank you very much.
Thank you so much for that kind introduction. And I just want to thank, on behalf of myself and Dr. Morris, thank you for the honor of participating in this very important inaugural session. And we're just truly honored. So thank you for those kind words, and I look forward to our discussions. So here is my talk right there. Are you able to see my slide?
Yes, perfectly.
Okay.
Thank you.
So this paper is titled Assessment of Femoral Head Revascularization in Leg Cap Perthes Disease Using Serial Perfusion MRI. This was published in 2016. Let's see how to advance this. Okay, so I think we all know Perthes is really a complex disorder, but I think we will all agree that this disruption of blood flow to the femoral head is the key pathologic process. So this is a patient in the initial stage. I hope you can see sort of my arrow. And by looking at X-ray, it's very difficult to know what's happening with the blood flow. So we've been using perfusion MRI, which I'll explain what that is, to define the amount of femoral head that is involved. The perfusion MRI is really basically, you obtain an MRI without contrast. It's a T1 fat suppressed imaging. And then you give contrast, and the patient has to be very still. And then basically you digitally subtract corresponding pre-contrast T1 images from the post-contrast T1 images, and then you get the subtraction MRI, which basically removes all the background. And the merit of this technique is that you really see where there's an absence of blood flow, for instance, in this femoral head, and where there's increased blood flow, which is in the synovium here. So this is an indication of synovitis. So we've used this technique and made observation that when you compare non-contrast to contrast MRI in the initial stage, it provides a much clearer demarcation of the area of involvement. As you can see here, these are corresponding non-contrast and contrast MRI, and you can clearly see where the area of involvement is. And we've also shown in this paper that if you obtain a perfusion MRI at the early stage, before you could declare the lateral pillar, and then follow patient up to the fragmentation stage, it could predict the lateral pillar in most of these cases. And then a further study showed that there is a correlation between femoral head perfusion at an early stage and radiographic outcome at 2 years. So there is an inverse relationship, as you can see by the R values here, that are significant. So there is if there's a lower perfusion, there's more deformity, as you can see on this graph. And finally, we found that using perfusion MRI, there's a significant increase in synovial hyperemia, and that this lasts for about 1.5 years or more. So this is initial MRI showing synovial effusion much higher in the affected side, you can see, and then the hyperemia is also high, and then it is maintained till about a year and a half or more. So we all know that there's a characteristic progression of disease, and this is the staging described by Waldenstrom as you go from stage 1, which is increased radial density, to fragmentation, to reossification, to the heal stage. And the important element of any necrotic bone healing is the restoration of blood flow, as it brings repair cells and factors into that necrotic area. But very little is known about the revascularization process in Perthes disease. So the purpose of this study was to determine the pattern and rate of revascularization of the femoral heads of patients in active stage of Perthes using serial perfusion MRI. So we prospectively enroll patients with Perthes who are assessed with perfusion MRI from 2007 to 14. Patients were in the early stage, as you can see here on the table here. Most of the patients were in stage 1. And we applied perfusion MRI, which was assessed by 2 independent observers. Basically, we used a software called HipVasc. And what it does is it sums up the area of enhancement based on thresholding, divided by sum of areas of the epiphysis. So for each patient, there's usually about 6 to 8 T1 images obtained, and all these were analyzed. And we found that there was a good inter-observer agreement of 0.88. So in terms of results, we had 29 patients, 30 hips, 15 were treated non-operatively and 15 operatively, as you can see here. Average age at diagnosis was about 8, ranged from 5 to 13. All patients had at least 2 perfusion MRIs, and most of the patients had 3 or more. And you can see that on the table here, number of MRIs and the number of patients who had it. And in terms of the duration, from the diagnosis to first MRI was about a month. From first to second MRI was about 6 months. First to third was about 10 months. And first to last MRI was a little over a year. So our finding was that we recognize the general pattern of revascularization starting from the periphery of the lateral, medial, and posterior region. And this is seen in the coronal and the sagittal views. As you can see, as we go from the initial MRI to 5 and 11 months, that you have more sort of enhanced area in the medial and lateral aspect of the epiphysis. And if you look at the sagittal view, you have enhancement in the posterior, and then they move towards the anterocentral region. So that region is the last region to revascularize, and it takes quite a bit of time to do that. And this, to some extent, correlates with X-ray finding. As you know, that region is the last to reossify as well. So this pattern looked like a horseshoe shaped, aiming towards the anterior central region. In terms of the percent perfusion, the initial MRIs reveal various levels ranging from 5 to 70%, with mean of 35%. And this is very important because this could potentially explain why some patients heal slower and have poor prognosis. So for instance, this 9-year-old female had 11% perfusion of the head, whereas this 11-year-old male, even though it was an initial stage, has 65% perfusion. So although the X-ray may look similar, this method allows you to identify different levels of perfusion, which potentially will have prognostic implication. And in terms of percent perfusion over time, average percent perfusion increase for all patients, and it was about 35% on the first MRI to 77% on the third MRI, which was over about 10 months on average. There was a greater gain of the percent perfusion between the first and second, and this is demonstrated on this graph here. Initial MRI, you see a big jump, and then a lesser sort of jump from second to third MRI. And this is an interesting phenomenon, why that there is this sort of tapering off of the revascularization. The rate of revascularization was calculated by subtracting percent perfusion of the first MRI from percent perfusion on the third MRI, divided by duration between the two scans, and the revascularization rate were highly variable among the patients, ranging from 0.6 to 10.4% per month. The average rate was about 4.9% per month. So this is these are case demonstration. A 6-year-old male treated with Walker. Average rate, as demonstrated on this graph, you see this patient, although very young or relatively young, had a low sort of rate of revascularization, whereas this 11-year-old female who was also treated with non-weight bearing, the rate was much higher. In fact, she was sort of on the average rate, which was 4.9% per month. And you can see that a jump here from 0 to about 6 months, and then further increase over time. It was interesting when we looked at patients, and this is an older patient, 13-year-old, patients treated with multiple epiphyseal drilling. This is the left is the side that's involved. And initial perfusion MRI revealed 23% perfusion. And you can see some of that on the lateral pillar region here, whereas the central and medial aspect lacked perfusion. And the patient was treated with multiple epiphyseal drilling. And when we compare the initial MRI to the 5 months post-op, you can see a significant increase, as well as these K-wire tracks showing enhancement, suggesting that the revascularization was in fact taking place, not just from periphery, like what we saw in non-operatively treated patients, but also through these tracks that were created by K-wire drilling. So here's some discussion points. We found no regression or fluctuation of femoral head perfusion. So this sort of questions this theory of multi-hit theory for Perthes disease. There was a discussion, and this is one of the reviewers' sort of concern, was the deposition of gadolinium-based contrast agents on brain and soft tissues. You know, at this time, there was really no clinical significance known in regards to that. There is brain deposition, and there are two types of gadolinium agents, linear and macrocyclic. And the macrocyclic agents produce less brain deposition. So this is the type that's preferred. And this is what we used in that study, as well as this is what we currently use. So macrocyclic is preferred gadolinium to be used. My current indications for perfusion MRI is patients over 6 in early stage. The reason for that is patients under 6 generally do well, so the perfusion MRI does not help me with treatment decision making, whereas over 6, there are evidence to suggest that early operative intervention is helpful. But we don't want to operate on everyone over 6, because as you saw from the study, not everyone has poor perfusion. Some of them have, in the very initial MRI, very high perfusion, and those patients could probably be treated with treated non-operatively with good results. We do serial MRI, but in very select patients who we are unclear about the progression of their healing and when we would allow them to weight bear, and patients treated with multiple epiphyseal drilling. What we found that in older patients, drilling their femoral head increases perfusion, but certain areas remain non-perfused, specifically the anterocentral region, and we would go and re-drill that region to speed up the healing process. In terms of future research, these are the important questions that we are asking. Why does the rate of revascularization decrease over time, as I've shown? And do operative treatment increase the rate of revascularization? And also, because of the concern for the gadolinium soft tissue deposition, we would like to develop non-contrast MRIs to assess necrotic femoral head healing. So here are some sort of more follow-up studies. These are preclinical, so animal model studies trying to develop specific MRI sequences for assessing ischemic damage and repair process. You can see some of these are new sequences that could clearly show difference between normal versus ischemic femoral head. This is at 48 hours, and difference in terms of the visible effects that you could see from these sequences. And we've also been working on this quantitative susceptibility mapping, QSM, to detect vascularization of the epiphyseal cartilage. You can see this is the control versus the operative side. This is using the Picklet model that we could demonstrate increased flow as well as details using this method. But these are clinical studies, so we are far from applying this clinically. So this study does have limitations: small sample size, inclusion of non-op and op patients, duration between MRIs, and number of MRIs obtained were not rigidly controlled. The strengths for prospectively enrolled patients, all patients were in the early stage, and 2 independent observers performed the HIP-VAS. So in terms of take-home message, pattern of revascularization is horseshoe-shaped, and the anterocentral region is the last to revascularize. Percent perfusion of the affected head is highly variable in the early stage, and this is important for treatment decision-making. So if the perfusion is good, we do not recommend surgery because they will do just as well non-operatively. Revascularization increases over time. On average, it's about 5%, so it's relatively gradual, and we need to have that in mind in terms of post-op management as well as the duration of weight restriction if you believe that works. As well, the rate of revascularization is highly variable, and this may have the prognostic implication of who will do well and who will not. And then future research is needed to determine if treatment can increase the rate of revascularization. Some other papers on perfusion MRI. This is a study from David Little's group comparing the subtraction MRI with standard contrast enhanced MRI. Basically, they found no clear difference, although they state that subtraction MRI do provide more clear demarcation of non-perfused areas. And this is a review article on advanced imaging of Perthes disease. So with that, I will end my prepared talk and be happy to answer any questions.
Thank you so much, Prof. Kim. I think there's some really valuable information that has come out from this excellent paper, and which has been clarified really beautifully well in your presentation too. And I'll ask Hitesh to begin the discussion. I can see quite a few questions already coming up in the chat box. Yeah. And I'd encourage everyone who has a question to ask, you can unmute yourself and ask, but preferably put it in the chat box so that's easier then for the moderator to go about his job. So Hitesh, over to you.
Yeah, thank you, Alaric. Thank you, Professor Harry Kim, for joining this session. Thanks, it was a wonderful talk and the paper. First and foremost question, because the perfusion MRI is not routine standard of care in India. So the question from the all audience and from the Indian perspective, what is the current status of the perfusion MRI in your practice? What you have already mentioned, more than 6 years. And question, you said already in your paper, you select case by case for repeat perfusion MRI. So what is your current practice? Would you do all the patient over 6 years or only early stage of disease? And second, which particular case would you do perfusion MRI, repeat perfusion MRI at present, 2021?
Yes, thank you for that question. So we don't do perfusion MRI on every patient. As you stated, only patients in the early stage of Perthes, because radiographically at the early stage, it's very hard to know how much of the head is involved. And that's why we usually, in traditional practice, usually follow patients to the fragmentation stage and assess their lateral pillar or amount of deformity that occurs. But this is not very proactive. And also the issue is you're waiting for the head to deform before you could treat. And so the outcome potentially would be compromised by that kind of wait and see approach. Whereas with perfusion MRI, you could identify how much of the head is involved. And if it's a severe involvement, then, and we've shown that it does correlate to some extent with the lateral pillar later on. So it helps us to decide who to treat and who to not treat. So just to reiterate, I only obtain perfusion MRI for patients over 6 in the early stage, because if they come at the later stage, then I could use a lateral pillar, which is a radiographic classification, to make treatment decision. In terms of the serial MRI, mainly used for older patients who I'm treating with multiple epiphyseal drilling, because I would like to know 3 months or so after how much of the head has revascularized through epiphyseal drilling. If it is insufficient, then we would go ahead and do this procedure again. And you have to remember that this procedure is relatively minimally invasive, basically just drilling 7 to 8 holes using K-wire. And in these patients in particular, we do inject bone marrow aspirate concentrate as done in adult AVN.
Okay, good, thank you. As far as I know, you have published many papers on perfusion MRI, but from the Indian's perspective, it would be useful to ask you how was the perfusion MRI was done? Whether the all were under sedation or some of them were under anesthesia? What was your protocol for repeated particular?
Very, very good question. So we don't have a set sort of age in terms of who will get sedation or general anesthesia. So we have published this study called Feasibility and Safety of Perfusion MRI. This was a retrospective study that included about 5 to 6 centers, looking at about 200 some patients that underwent about 300 MRIs, I think. And what we find that if the patient is young, so 6 and 7, they probably will require anesthesia, but not all of them, because there's some very mature 7-year-olds. And I'm sure Indian children are much more mature than American children and are able to go through this procedure without sedation. If you're over 8, most of them are able to stay still. And what we provide is video goggles where they can watch a movie, and most of them work out well without having any kind of sedation. But this paper was published in JPO, I think, 2014 or 2015.
Yes. Another point is there, the FDA has raised some issue for the drug safety, particular for perfusion MRI, due to the contrast deposition in the brain. And we don't know at present in 2020 what is the actually long-term outcome or the problem with the brain deposition with gadolinium contrast agent. So what is the...
Yeah, so that's a very good question and comment, and I addressed it partly. I think it's important to remember we really don't know the clinical significance. There is deposition, but it could be decreased using so-called macrocyclic gadolinium, and that's why the risk and benefit has to be sort of balanced in terms of what benefit do you have by getting or not getting perfusion MRI here. And we do use it for treatment decision making, and we do repeat MRI on certain patients, but it has to be case by case. But you have to also remember, we don't really know the significance. And MRI, perfusion MRI, has been done, I think, over 300 million or so or more cases has been done in the world for various indications. So in terms of safety, it is very, very, has a very safe profile. And I think there's going to be more research coming up in terms of what is the significance of brain deposition. So you should have some caution as to who do you apply it to, and it should have some clinical, I think, importance for you to obtain it.
Okay, thank you. One more question related to study. When we compare about repeated perfusion MRI, as you have already mentioned, whether it is very difficult to compare with the number of MRI. So how would you overcome? Because what could be number after the 2015 for repeated perfusion MRI? So we are asking 2 MRI versus 6 MRI.
Yeah, so I think you have to, yeah. So this paper came out on 2016.
Yeah.
So all these MRIs were done before I think, a recognition of brain deposition. So the first paper, I think, on the brain deposition of gadolinium was published in about 2015.
Yeah.
So so prior to that, there was no concern about soft tissue deposition. That's why we had all these serial MRIs. And that was one of the, I think, concern from the reviewer point of view as well, that as this become more recognized in a later time, how safe is it? Like I said, I now rarely would do more than 2. And it's really just for treatment purposes and indication for patients who's going to have multiple epiphyseal dysplasia.
Yeah.
Thanks, Hitesh. We just have a couple of minutes more. So there are a few questions in the chat box. So we'll take some of them.
Yeah.
Someone asked, how is the percentage perfusion calculated? Your paper mentions the HipVAS software. In case you don't have that software, is there any manual method of calculating the percentage perfusion, Dr. Kim?
So yes, if you don't have that, I think you could use like some kind of Photoshop type of software to basically figure out the pixels in the epiphysis in all the slices, and then pixels that have a certain threshold intensity that would suggest that there is perfusion. So it could be done, and that's how it was done originally before we developed that software. And that's published in our previous our articles that I sort of stated how we did it originally. I think it was published in 2013 and 2014.
Right. Thank you. There's another question that you've said that the perfusion MRI sometimes leads you to surgery in the form of the multiple drilling. And the question is, after you've done that, what is the amount of time post-op that you would recommend the next perfusion scan to see the effect of your drilling?
That's a good question. Just so remember this, that multiple epiphyseal drilling is done for teenagers, patients who are bordering on adulthood, just because there is a concern about damaging the growth plate by drilling through. So I would not recommend that for younger patients. And there's no reason to believe that it works better than sort of standard treatment. Multiple epiphyseal drilling is an accepted treatment for adult AVN. The follow-up perfusion MRI is done 3 to 4 months after the initial treatment.
Great, thank you. There's a question which says that the necrosis or the infarction may not be total. So when you say 50% perfused, how do you know it's intact 50% or revascularized? Sandeep, can you elaborate on that question since you've asked that? I'm not sure what that means.
So I think the question may be, maybe the whole head is vascular, and when we get a perfusion scan,
I was just sorry. Can I just clarify? Hello.
Prof. Kim, you're already answering that, I think. So let him go ahead.
So no, go ahead if you want to clarify.
No, I just wanted to know, since the infarction is supposed to be a one-time event or it's multiple infarcts, at what point in time do you decide that what you are seeing on MRI is residual head which is being perfused and half the head is having an infarct, or it's a complete infarct which is 50% revascularized? Is the appearance different when it is a residual vascular head or a revascularized head?
So that's a good question. So when you look at the signal, and I'm not sure you were able to appreciate it, there are areas of the head that is vascularized that has a normal intensity as the opposite side. So those are probably uninvolved part of the head or already healed. And there are areas that are very hyper intense in terms of the signal. Those are the revascularizing area, because as the vessels come in, there's also resorption, there's more blood flow. That's some way to sort of identify. And also that is a complicated question because patients present at different time point from their initial sort of the event, right? So it's hard to know for sure, but during the duration that we study, which in most patients was over 1 year, we didn't see this fluctuation, as in if there was a second event within that 1 year, then you would see a less perfusion in those serial MRIs, or it would be going up and down. But we didn't see that.
There was a paper which spoke of nuclear scans, and they proposed theories that there is either recanalization and revascularization. And those who recanalize usually don't collapse, whereas those who revascularize are softer bone and they collapse. So did you find any such variation when you did a perfusion MRI vis-a-vis a nuclear scan?
I think I spent a pretty big paragraph explaining and comparing that. So I would refer to you in the discussion section of this paper. That's well written.
Yeah, thank you, Prof. Kim. Couple more questions. Taral says you showed a 6-year-old child with a 20% perfusion as an example. Would that child be a candidate for epiphyseal drilling?
I would say no, because I already stated I use it for teenagers and adult or close to adult.
Sure.
Do
and
not
a final
drill
question.
6-year-olds with because you're going to cause a growth plate damage. Plus, there's no evidence to suggest that that form of treatment works for a 6 or 7 or even 8-year-old. Older patients, the reason why we do it is because there are clear adult studies that show type of core decompression using small multiple drilling does work.
Sure. So a final question, Prof. Kim. This was really a wonderful discussion. A really burning question that, when you talk of a stage and you say early stage of the disease, that's still a little nebulous because that runs over several months. So you have a patient who comes to you, say at a very early stage. At what point in that timeline, in that early stage, which runs over several months, would you recommend a perfusion MRI?
So it depends on the age of the patient, but again, over 6 in the early stage, I would generally recommend perfusion MRI, but it would also depend on parents. So that, in US, we have to sort of have treatment decision-making with parents. If the parents are not going to, or not interested in operative treatment, then I don't see a reason to get it because it's not going to change their mind on treatment, that they're going to choose. But if they're open to operative treatment, I would obtain it because it has prognostic value from the very early stage.
Great. Thank you very much, Prof. Kim and Hitesh. That was a really excellent presentation and the moderation by Hitesh. And we'll move on to the next paper. If I can ask Will to share his screen, please.
All right, can you see the screen?
Yes, thank you very much.
Perfect. Well, first I want to echo Dr. Kim's comments that this is really a privilege for us to have the opportunity to speak to the group, and really exciting for us to be able to share our papers. As you can see, Dr. Kim is the senior author on this study that we worked on together, and so I'm sure I'll have some fantastic input as well. But I look forward to speaking with you about secondary surgery and residual dysplasia following late closed or open reduction of developmental dysplasia of the hip. So there's been growing literature over the past few decades showing the association between residual dysplasia and closed reduction of developmental dysplasia of the hip. Malvitz and Weinstein out of Iowa reported on 152 congenitally dislocated hips in 119 patients with a mean follow-up of 30 years and showed that there was residual dysplasia in greater than 50% of those patients at skeletal maturity. Turgeson's group out of Norway reported on 50-year follow-up of 90 hips in 71 patients that underwent closed reduction and showed that there was residual dysplasia in almost 40% at skeletal maturity, and that by that 50-year follow-up time point, almost a quarter had already undergone an early hip replacement. Both these and other excellent long-term studies included patients who underwent closed reduction at up to 8 years of age, though, which isn't really consistent with our current practice at Scottish Rite, where a closed reduction is generally considered around 6 to 24 months. More recent studies adhering to those treatment principles have reinforced those findings, though, where closed reduction was associated with secondary reconstructive surgery for residual dysplasia of 35 to 58%. And in fact, Bolland et al. Reported in 2010 that open reduced hips were about 3 times less likely to require secondary surgery for residual dysplasia than their closed reduced counterparts. However, both of these studies that included kind of the guidelines that we use currently of that 6 to 24-month time period in terms of age were intermediate follow-up studies. And so there's really limited long-term outcomes data looking at these types of patient populations. So the purpose of our study was to compare long-term outcomes of patients treated by closed or open reduction for late detected DDH between 6 to 24 months of age with regard to secondary reconstructive procedures and residual radiographic dysplasia. In order to accomplish this, we identified all of the closed and open reduced hips between 1980 and 2008 that were performed on patients between 6 to 24 months of age. We included both medial and anterior open reductions, so those with or without a capsulorrhaphy, but we excluded those that had a concurrent pelvic or femoral osteotomy to remove additional variables that may have influenced the amount of residual dysplasia. And all of these patients were followed until a minimum of 10 years of age. Based on these inclusion criteria from an initial sample population of 342 hips, we ultimately ended up with 158 hips in 139 patients. We obtained demographic data, including the age at reduction, laterality, gender, as well as the severity of dislocation using the IHDI classification system. So since I understand there are trainees in the audience, including residents for whom they may not be familiar with this, the IHDI classification grades the severity of the dislocation based on the midpoint of the metaphysis. That's the dot that you can see on the metaphysis on the right, relative to Perkins and Hilgenreiner's lines. So as you can see, the further that metaphysis migrates laterally and superiorly, the more severe the dislocation. Our primary clinical outcome was the need for secondary surgery, and our primary radiographic outcome was residual dysplasia, measured both at 10 years of age, that minimum follow-up, as well as at triradiate closure for the majority of patients who were followed until that time point. We looked at 4 different markers of acetabular coverage: the lateral center edge angle A and Sharp's angle D, which look at lateral coverage; the femoral head extrusion index B, which is a marker of the lateralization of the head; and then the tonus angle C, which is a marker of the inclination of the acetabulum. We also looked at avascular necrosis as determined by the Buchholz-Ogden classification system, which is depicted to the right. So you can see that grade 1 is just a hypoplastic epiphysis, while grades 2 through 4 reflect either valgus, varus, or more significant head involvement. So it's really grades 2 through 4 that are considered clinically significant. So of those 158 hips that were included, 104 were closed reductions and 54 were open reductions. When we compared those 2 cohorts, there was a non-significant trend for the open reduced hips being older at time of reduction. And the open reduced hips also seem to have, on average, more severe hip dislocations. So we only had pre-reduction radiographs on 117 of the 158 hips included, but most of the open reductions were performed in IHDI-4, that most severe dislocation, while the majority of the closed reductions were performed in IHDI-3 hips. The open reductions were also followed significantly longer, but as you can see, the mean follow in both cohorts was greater than 15 years. There was certainly excellent long-term follow-up in both groups. We started looking at the secondary procedures, and you can see that closed reduction was associated with increased secondary surgery, where the closed reduced hips underwent secondary surgery 47% of the time, compared with open reduced hips, which only underwent surgery about 30% of the time. However, there was no difference in the time to secondary surgery between those cohorts, in both cases around 5 years of age. We performed a mixed models analysis of factors that could predict the need for secondary surgery, and we found that age at index procedure, as well as closed reduction, were the 2 significant factors, while gender, bilaterality did not predict the need for secondary surgery. For those less familiar with those statistics, the odds ratio means, for example, for age index procedure, that if you compared a 6-month-old and an 18-month-old, that the 18-month-old would be 2.7 times more likely to have a secondary surgery compared with a 6-month-old. Similarly, a patient who underwent a closed reduction had an odds ratio of 2.6, so 2.6 times more likely than an open reduced hip, with all other factors accounted for. We also broke down the rates of secondary surgery by the severity of the dislocation using the IHDI classification system. And you can see that there was no significant difference in the rates of subsequent surgery when you looked at IHDI 3 hips only. However, when you looked at the IHDI 4 hips, almost 60% of the closed reduced hips required secondary surgery, while only 17% of the open reduced hips did. Lastly, for secondary procedures, we broke down the groups by their age at index reduction. So when they went in for either that index closed or open reduction. And if we look at those differences in rates based on age, the older the patient, the more likely the closed reduced hip required secondary surgery. You can see that at less than a year of age, a closed reduced hip was only reoperated about 28% of the time, while at greater than 12 months of age, that rate was over 50%. In comparison, in open reduction, there was no significant difference regardless of the time or the age of reduction, in all cases around 30%. When we looked at the radiographic outcomes, specifically the rates of residual dysplasia, we looked at this 2 ways. The first way we looked at it was in that subpopulation that did not have secondary surgery, meaning those that did not have a secondary corrective osteotomy. And that cohort is about 60%, 59% of all of our hips. And when we looked at all of those patients at 10 years of age, we saw that the open reduced hips had less residual dysplasia or had better acetabular coverage compared to the closed reduced hips in terms of both the lateral center edge angle as well as the femoral head extrusion index. 89% of this group was followed all the way until triradiate closure. And again, we saw that the open reduced hips were less dysplastic than the closed reduced hips based on the lateral center edge angle, femoral head extrusion index, and Sharp's angle, with no significant difference in the acetabular inclination. We then went back and included all the patients, meaning those that underwent a closed or open reduction, even if they had a subsequent pelvic osteotomy. And 89% of that group was followed until triradiate closure. And again, the open reduced hips were less dysplastic than the closed reduced hips with respect to the lateral center edge angle. You can see it's a mean of about 4 degrees. However, the previous differences that were seen in the femoral head extrusion index and Sharp's angle fell out of significance. Notably, there was no difference in the rates of clinically significant grades 2 through 4 avascular necrosis, in both cases around 20%. So in terms of the discussion points and what came up as we were preparing the manuscript and having it reviewed, a main limitation of this being a retrospective review is that this is a comparison of dissimilar cohorts. We highlighted that the open reduced hips had a more severe dislocation with a higher IHDI and had a non-significant trend towards being older at time of reduction. However, the open reduced hips were the ones that demonstrated what appear to be improved clinical and radiographic outcomes, and both increasing age and more severe dislocation based on IHDI are both factors which otherwise predict higher rates of secondary surgery. The outcome of secondary surgery itself is also inherently flawed, and this was a lot of discussion during our peer review process. This study spanned 30 years at a large tertiary referral center and included 11 surgeons. Consequently, there was not one rule that was followed in terms of which patients with residual dysplasia needed to have surgery and which didn't. Consequently, we saw some patients that had residual dysplasia that were treated with a subsequent pelvic osteotomy and others that did not. And we tried to address this by looking at both the rates of secondary surgery as well as those rates of residual dysplasia in the patients who did not undergo secondary surgery. And so there's a nice summary slide that was both in the paper and I'll bring up at the end, which I think informs this point well. The last significant limitation is the absence of functional outcome scores. So one of the concerns at our institution when we discussed an open reduction is that it violates the hip joint as compared to a closed reduction. And it also requires release of hip flexors, mobilization of abductors. And so it may theoretically have long-term implications in terms of stiffness, weakness, gait changes. And so there was no functional testing to compare these two groups or any patient-reported outcomes measures that could evaluate this aspect of the patient's outcome. To put this paper in context with some of the recent literature, two of the papers that I briefly mentioned at the beginning we'll look back at now. So Scott Luman out of WashU reported on 153 patients that underwent closed reduction between that 6 to 24 month of age, up to 24 months of age. And they noted that about 35% underwent secondary surgery, which is pretty similar to our group, slightly less, but we also had longer follow-up. They also highlighted that there was an increasing rate of secondary surgery with increasing age, just as we demonstrated. And they also went on to really advocate for an early reduction, as they saw no difference in the rate of avascular necrosis based on the presence or absence of an ossific nucleus, which is one of the factors that surgeons consider when they're deciding whether or not to perform an open reduction. So they didn't see that that seemed to affect AVN, and they advocated for an early reduction. Nick Clark's group out of England published a study here, Bolland et al., where they retrospectively reviewed 134 open reduced hips and 104 closed reduced hips, and noted that the open reduced hips were almost 3 times less likely to have subsequent secondary surgery, again with a similar rate of avascular necrosis. And so this, with a more stark contrast, is a very similar finding to what we demonstrated, which kind of further builds evidence that there may be improved outcomes with open reduced hips. To summarize everything that we presented in the paper, if we look at all of our closed reductions and our open reductions, about 50% of the closed reduced hips went on to have secondary surgery, compared to 30% in the open reduced group. And if we follow those hips that did not have secondary surgery, almost 60% had residual dysplasia, compared to about a third of the open reduced hips. I should note that in these cases, this residual dysplasia, about 50% of those patients in both groups, it was borderline dysplasia, so a lateral center edge angle between 18 and 25 degrees, which there's growing literature about that as a target population for treatment, and at least short-term outcome studies showing good results in treating those symptomatic patients. But certainly this is not the same as severe dysplasia. And so if you put all this together, about 75% of the closed reductions either were treated for residual dysplasia with a secondary surgery or had radiographic residual dysplasia. So when I'm counseling families, this is something that I really highlight, that everyone will be excited if we don't make an incision in the operating room because we have a beautiful arthrogram and a very stable reduction, but that comes at the long-term cost of knowing that there's a high rate that we're going to be coming back to the operating room for some secondary surgery. Similar to the existing literature, we showed that risk factors for residual dysplasia or secondary surgery include patients that are over than 12 months or have an IHDI4 dislocation who undergo closed reduction. And so we have a slightly stronger consideration now for performing an open reduction if there's maybe a little less stability there, kind of borderline stability, or perhaps equivocal arthrographic findings that would suggest that they may not be a perfect reduction. And so I think the pendulum in our field is swinging a little bit more towards open reduction based on ours and other studies, but certainly further study is needed to evaluate whether there are functional consequences of performing an open reduction as compared to a closed reduction. In terms of future directions for our research, we've been examining whether there are other intraoperative factors you can identify to try to distinguish in those in-between patients who may be a better candidate for an open reduction, other than the patient that's over 12 months with an IHDI4 dislocation. So we've looked at arthrographic findings and are presenting a paper at POSI this year with those results. Additionally, as I touched on before, I think it's going to be very important for us to look at long-term functional outcomes in patients that have had closed or open reduction to see whether there are consequences in range of motion, strength, or gait. And that's something that we're beginning at Scottish Rite. So I think there's a lot of exciting research to come in this area, and I think a lot more that we can learn that will influence practice. And so we're very excited here at Scottish Rite and appreciate your attention and look forward to answering questions. Thank you.
Thank you so much, Will. I think that is really an excellent paper because it helps inform so much in our decision-making process and questions long-held beliefs about the role of open versus closed reduction. I think it's these long-term studies like this which are extremely valuable to literature, and you've really highlighted the strengths and the limitations of your study really well. So I'll ask Manoj now to lead the discussion. We have about 10 minutes to discuss very quickly if there are any questions that either Manoj you have personally or from the chat box.
Thanks, Alaric. Great presentation, Dr. Morris, and I enjoyed reading the paper as well. So let me kick off with a few questions. Your study group included children presenting a delayed presentation between 6 to 24 months. Were they all presenting, was it their first presentation, or did you have children who failed public harness? And where does that fit in the algorithm to predict whether they would need an open reduction or a closed reduction? If they had a prior public harness, would that influence your decision making?
That to my knowledge did not influence the decision making. So to answer the two parts of the question, first we originally had termed this late detected DDH, and the title of the paper changed slightly because it's an important distinction that, to your point, many of the patients were identified before 6 months of age and had failed public harness treatment. Every patient that was treated with an open reduction, going back through all of the operative reports, because this was, as I mentioned before, a group of 11 different surgeons over 30 years. So, none of them were my cases because I'm a newer staff member, and these were older cases. But looking through all of the patients that had an open reduction, either it was unstable or they just couldn't reduce it at all. So the information about whether or not they had been treated with a public harness, everybody less than 6 months, with the exception that was identified less than 6 months, with the exception of, I think, literally just one or two patients had failed public harness treatment first. So I don't think we would have had enough of a group to try and compare whether that was a predictive factor, more so than just the age at time of reduction, that the older they are, the more likely they were to require an open reduction.
Okay. So I have another question. You have used residual dysplasia here as the outcome measure. I know that this group is an assorted group of 11 practicing surgeons. There are a lot of surgeons who treat residual dysplasia with hip abduction bracing. What is the current philosophy with regard to that? And in this group, were there patients who were treated with hip abduction bracing, and would that have had any influence on the final outcome measure in terms of residual dysplasia secondary procedure? And what's the current practice with regard to hip abduction bracing for residual dysplasia?
That's a great and very timely question, because Dr. Kim and I are actually looking at that question right now, because it's surprising that there's not really much literature providing evidence for that value. There's a couple of papers looking at residual dysplasia at 6 months of age and using an abduction brace at that point, showing that there's some improvement in the acetabular index, but there's not really a concrete answer about whether or not that helps. Consequently, among the surgeons currently at Scottish Rite, we are all over the place. I think Dr. Kim and I favor coming out of a cast and into an abduction brace, because intuitively it seems like it should make sense. But we don't have the answer for whether or not that actually helps. And there's really sparse literature about the role of abduction bracing. So that was not a factor that we included because it was not something that was consistently done by the surgeons, and it may play a role, but we don't know just yet.
Okay. So with regard to, if I could kind of push you further in terms of committing in terms of indications for open reduction here, I think all of us will agree that the severe grades will definitely benefit from an open reduction. But looking through the evidence in the literature, the age itself is a mixed bag there. I think as recently as last year, I think there was a paper from 4 centers in the US, which again looked at the burning question for the practicing surgeon is, when should I be opening it? And can we say that, confidently say that all children about 12 months, it would be better off opening? Because I think the paper from last year, they said that age is not a factor. It's the severity which matters, the HDI grade or the Tonnes grade, whatever you want to use.
Well, I mean, at least in our study, obviously you have to aggregate all of the data that's out there. When we controlled for both, when we looked at, I guess we could not separate on our mixed models analysis age and IHDI factor or IHDI grade because of the overlap there, which does make that difficult to distinguish the two. I'm trying to think as you ask the question of which exact paper you're referring to, and it's not coming immediately to mind. But I think that an important piece of information before committing to saying we should be opening all of the older patients is that functional outcomes data. It's very interesting. We have a conference every Monday night where we go over everybody's cases, and we hear people talk about, and I brought this up at the end, that with an open reduction, you worry about opening the hip capsule, you're releasing muscles and mobilizing muscles, and what are the long-term implications of that? And there's not really a lot of literature looking at, functionally what's happening in terms of their strength and gait. And that's a question that we're working on answering, and hopefully we'll give you all some good information in the future. But I think until we know that, we can't, I would be hesitant to say we should be opening all these cases, all these patients that are greater than 12 months of age. But I think that the two big points that I take away from this is that for Dr. Kim and I, we both do medial open reductions. And if that's a tool that you have in your tool belt, I would encourage you to say, okay, well then, when our anesthesiologist talked to us about anesthetic risk, it looks like 6 months is a point when it's a little safer to go to the operating room. And so when I counsel families that have failed Pavlik harness, we're going to the operating room around the 6 or 7 month age, and we're going to get the hip in the socket, whether that's a closed reduction or a medial open reduction, if that's a technique you're comfortable with. Otherwise, at greater than 12 months of age, I can't say that I would do that for every patient, but my threshold is much lower if I feel like we don't have a good safe zone, rather than saying it'll probably be okay and not really being happy with the stability of the reduction to try and avoid an open reduction. I think that this builds evidence that we see that there's not a significant difference in rates of avascular necrosis between closed and open reduction, which has been shown multiple times in the literature. And that also they seem to have better outcomes. So far, again, based on a few different papers here, that you may be saving the patient subsequent trips to the operating room and treating it effectively at this younger age, when there's also great literature about the ability of that socket to remodel. So it's certainly still not black and white, but I think that again, that pendulum is swinging to where I think that surgeons are becoming more aggressive if you're either not happy with the appearance of that reduction arthrographically or in terms of stability, to feel more confident that you're doing a good thing. If you feel uncomfortable or unsure that opening that hip is going to lead to good outcomes and is not, based on the literature recently, increasing the risk of things like avascular necrosis, which previously worried us.
Thank you, Dr. Morris. Al, I think if there are questions from the audience,
Yes, and going along the same theme, there's a question from Pranay who says that that's a really provocative decision about the role of open and closed reduction. So he asked, looking at these data, do you recommend that we should even lower the age for closed reduction? That means if the Pavlik harness fails, would you consider a closed reduction at 4 months rather than waiting for the traditional 6 or 8 months of age?
Sure. And I realize, by the way, that Dr. Kim has his video and audio off, but I certainly welcome him to provide input on any of these questions. He's a tremendous mentor, during this process, and has great insight as well. We had a lot of patients that we excluded for the study that had their closed or open reduction, usually closed, less than 6 months of age. Currently, in discussion with our pediatric anesthesiologist, I think that the kind of risk profile for the anesthetic itself, it seems that it decreases over those first 6 months. And so I think for a lot of us, we use 6 months of age as a time to then consider going to the operating room in terms of the anesthetic risk. So I don't know, Dr. Kim, I'd love to hear what your thoughts are, but for me, I think of it as a single trip. So it's 6 months of age, 6 or 7 months of age. We're going to the operating room and we're going to go to sleep and either get that closed reduction, which is usually likely successful at such a young age. And if not, we're going to do a medial open reduction to get the hip in, again, with the idea of trying to reduce that rate of residual dysplasia. But I usually don't bring the patients earlier than that based on our discussions with pediatric anesthesia, but that's not a universal thing. So Dr. Kim, what is your practice like?
No, I agree with what Dr. Morris said, that it's really a balance of risk of laryngeal spasm or general anesthetic sort of issues in a very young baby versus sort of safety. So I would also tend to wait till about they're 6 months old. I mean, I think if you have a great anesthesiologist like we do, but once in a while we'll run into this kind of situation. And Dr. Herring, my mentor, would say that, it's nothing like having a baby that goes into laryngospasm and, it'll just, it's scary to see that happen. And it does happen once in a while. So, and just so that you get a better, like earlier hip reduction to risk that, to me is not worth it. Just wanted to add, regards to the closed reduction versus open, just like Dr. Morris says, there's a lot to be studied and learned. So I think, people want just sort of quick answer, but it's a complicated issue because closed reduction, we still don't know what is the optimal amount of casting. So for instance, any kind of drug, there is an optimal dose. And we don't really know that. And I don't think our study clearly sort of defined that either. So, most of us would cast till 3 months, and that's just sort of like a, brainstem reaction rather than thinking about some patients will need longer duration. And perhaps those older patients are the ones that need longer duration of casting. So that needs to be sort of studied before everyone jumps into the open reduction camp. I think that's important. The other thing is, when you do an open reduction, there's nothing like failed open reduction to screw that hip up. So just remember that as well, that, before everyone jumps into an open reduction camp, you have to sort of balance the risks and benefits. But there's definitely then this question really goes to the selection, which patient would benefit by having open reduction, and then risk is sort of, not sort of manageable doing that.
Thank you, Dr. Kim. I think another important variable, of course, is the skill involved in closed versus open reduction. Which is more difficult? Is it difficult to do a closed reduction or more difficult to do an open reduction? And you're in a tertiary care center where you have some really skilled pediatric orthopedic surgeons who have years of experience in both the procedures. So it'll be interesting to note that when we look at some other centers of different cadre of physicians or surgeons and the skill involved in closed versus open reduction, that for a general sort of pediatric orthopedic surgeon, not really a hip specialist, what would be or what would give the better results, a closed reduction or an open reduction in terms of the skill that's required? So any comments on that?
That's a great question. I think there's certainly a lot of literature about the learning curve for open reduction. And so if it's somebody that's not doing a lot of open reductions, then it may be somebody where the outcomes are not as good as compared to a closed reduction and doing an osteotomy later in the event that they're part of that majority that has residual dysplasia. And so, that's an excellent point and something that's been well described, that you need to have that volume and that experience to do a really successful open reduction. Dr. Kim, it looked like you're about to say something too.
No, I think I would agree. Open reduction definitely, technically, I think difficult if you do not do them regularly. And it also goes to capsulorrhaphy. Sometimes they tend to be very tight, so that you would maintain that reduction, but then it leads to stiffness, which is something that we didn't examine either. But on the other side, closed reduction and casting, of all the casts that we have to apply, putting a cast on a 6-month-old is a very sort of difficult process as well, because the baby is small. And that's one of the other reason why I usually wait till they're at least 6 months old, because you have a reasonable size to be able to put a cast on. And we use the a plaster followed by fiberglass, just to make sure that we get good molding. I don't know if I answered that question, but that's sort of the thoughts that comes to mind.
No, that's perfect, absolutely. A last comment, I think we have some other hip specialists also on our call today, and we have Prasad here. Prasad does a lot of work around the hip. And Prasad, do you have any questions or do you have any comments to make on this or the previous paper? Okay, he's probably muted. Prasad, are you there? Otherwise, we take a last question from Rujita, which says that, are there any signs on the arthrogram which are indicative of the need for surgery when doing a closed reduction? So did you all find anything specifically that can prognosticate the fact that the closed reduction may fail and the child is more likely to need an open reduction based on your arthrogram? Will and Harry?
So we'll have a whole nice presentation on that at POSI this year with turn the e-posters into kind of 4-minute talks. And then we'll be publishing it, soon. Unfortunately, we don't have a really exciting, one thing to look at. Just to Dr. Pudman's question earlier, there's not one factor that we were hoping to identify that suddenly tells you that this is a red flag and you need to perform an open reduction. So this is, as expected, a very complex issue, and we don't have the answer just yet.
I think part of the thing is we go sort of blinded to some extent in regards to the acetabular retroversion, femoral head aneversion, laxity of the patient, all these things that we don't know. That's why the answer is not very clear cut, because we're sort of treating patients with a lot of unknowns, I think. But Dr. Morris has done great work in this arthrogram and closed reduction versus open reductions, and definitely more work needs to be done.
Thank you so much. I think you've had a really fabulous presentation and discussion. We have all benefited a lot from this. And to wind up, I'll ask Rujita to give a short vote of thanks.
So I would definitely extend my heartfelt thanks on behalf of the Department of Pediatric Orthopedics at Wadia Children's Hospital, both the gentlemen, Dr. Harry Kim and Dr. Will Morris, and to Dhiren Bhai for facilitating this and really thinking of this wonderful idea. I think research often raises more questions than it answers, but I think that really suits the purpose of today's discussion, especially the kind of engaging discussion that we've had, that we must stimulate minds to think, and we must always be thinking on our feet as well while we are treating our patients, so that we ultimately translate it into the best outcomes for these patients. Because I think only by taking a look at especially long-term studies, the way both of you all have shown, that is the only way that true wisdom really emerges. So I thank both of you all once again. And I think we are all travelers on the same journey. And I hope that we have many more such things to do in future. And just an idea, if I may take the liberty, Dr. Dhiren Bhai and Sandeep, since both of you all are here, when we look at the Indian scenario, late DDH is almost something right from 5 years to 15 years rather than 6 months to 2 years. So if we could in future think of some collaboration between POSI and the arthroplasty surgeons to take a look at the kind of data that they've come up with in this paper, I think that will be a huge way forward to give the answers for our Indian patients. So thank you again for everyone for tuning in. And stay safe and take care.
Thank you very much.
Bye, everyone.
Night.